Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, a conversation on fertility and cancer. I'm Katie Armsby with Cancer Support Community Atlanta. If this is your first time joining a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual and in-person oncology support programs available at no cost. There you can see our complete list of the nutrition classes we offer, some great stress reduction programs like yoga and Tai Chi, support groups led by licensed mental health professionals, and of course, education classes like these. Again, we invite you to visit our website, cscatlanta.org, where you can see a complete list of the available programs. You can also click that video library tab where you can see all recorded past events. So if you ever miss a live event, you can find a recording of the program there. So without further ado, I'm excited to welcome today's program moderator back to this virtual platform. We've had Emily Beard here a few times before, and we're so happy she agreed to return. Emily Beard is the program coordinator overseeing breast cancer program development at Northside Hospital Cancer Institute. With a bachelor's degree in nursing from Emory and certification in oncology nursing and breast cancer care, Emily has worked as a nurse navigator, patient advocate, and program coordinator. She has a special interest in developing initiatives for young people with cancer, specifically in the areas of hereditary cancer, fertility preservation, and sexuality and intimacy. Emily is also the board chair for Team Maggie's Dream, an Atlanta-based nonprofit supporting young cancer survivors with advocacy and resources, including small grants to defray fertility preservation costs. So with that, welcome back, Emily, and I'm going to pass it off to you to get things started.
It is my pleasure to introduce Dr. Adam Pyrzak, a board-certified obstetrician and gynecologist with a specialization in gynecologic oncology. He has expertise in treating women with complex, benign gynecologic disorders such as pelvic masses, endometriosis, fibroids, and many others. Dr. Pyrzak also offers comprehensive and personalized cancer care, both during and after treatment. And Dr. Pyrzak's passion to help others fight cancer motivated him to get a master's degree in health services and outcomes research. His research has been published in multiple peer-reviewed journals and has been presented at the country's most esteemed conferences for oncology research. During his free time, he enjoys spending time with his family and friends, traveling and supporting the Georgia Bulldogs. Go Dogs! It is also my pleasure to introduce Dr. Jessica Kanter. She is board certified in obstetrics and gynecology and in reproductive endocrinology. She has traveled across the country presenting topics including in vitro fertilization with pre-implantation genetic testing, enhanced embryo implantation, and age-based counseling for fertility treatment. Dr. Kanter has contributed to medical publications in addition to writing book chapters detailing infertility and ectopic pregnancies. She currently sees patients at Shady Grove Fertility's Marietta and Atlanta campuses. The Atlanta campus is near Northside Hospital. In her free time, she enjoys spending time outdoors, diving into a new book, or experiencing new cultures and the wonders of the world through traveling. So without further ado, I will pass this off to Dr. Pyrzak to jump into a conversation around GYN malignancies and the impact on fertility. Dr. Pyrzak?
Hi, my name is Adam Pyrzak. I'm a gynecologic oncologist with Atlanta GYN Oncology based out of Northside Hospital in Atlanta. And today I'd like to talk to you about cancer and how that impacts your fertility. So today our learning objectives will include learning about the different types of gynecological factors and the risk factors associated with them, I want to review the strategies of how you can reduce getting these cancers, as the most important thing to preserving your fertility is reducing your likelihood of getting these cancers. I also want to discuss with you what is appropriate cancer screening, so you'll know the steps that you can take to, again, reduce your risk and avoid getting these cancers, but then also discuss strategies to reduce your risk of infertility that's associated with cancer and its treatments. I think first and foremost, it's important to understand that most cancers that are going to affect your fertility are going to be gynecologic cancers. There are many different types of gynecological cancers, and those include the fallopian tubes, which can cause their own cancers, or the ovaries, which also can cause a cancer, the uterus, which can form an endometrial cancer or an actual cancer within the muscle of the uterus, or cervical cancers. And then there's also rare types of cancers, the gynecological tract, which include vaginal cancers and vulvar cancers. Having said that, the most common types of gynecologic cancers that we see are cancers that involve the uterus, the cervix, and the fallopian tubes and ovaries. And so, for the sake of this discussion, I really want to focus on those cancers, as those have the most likely chances of affecting your fertility. The most common gynecologic malignancy or cancer that we see in the United States is endometrial cancer. There's over 67,000 cases of it diagnosed annually in the United States alone, and it's the most common cancer we see in the United States within the female genital tract. Most importantly, as you can see in the right lower corner, the rate of these cancers is increasing year after year. And most recently in 2024, endometrial cancer became the number one leading cause of death among all gynecologic malignancies. Typically, we see this cancer affecting women in their 60s, but with increasing obesity, we actually see a higher proportion of women in their 30s and 40s getting this gynecological cancer. And so that's something I want to focus on. The risk factors really associated with endometrial cancer include increasing age, but also unopposed estrogen or tamoxifen. And so these are conditions in which people might be overweight. As we can see, obesity and diabetes is also associated with increased risk of developing endometrial cancer, or certain genetic conditions such as Lynch syndrome, Cowden's, or a heavy family history of endometrial cancer significantly increases your risk factors. So it's really important to know what are your risks. And because there's no screening test for endometrial cancer, understanding these risks and what tests we can do to help identify this early and preserve your fertility are really important. And if you have these risk factors, there are certain things that can protect you against them. Pregnancy, more increasing pregnancy actually reduces your risk. Birth control pills, hormonal secreting IUDs, specifically ones that secrete progestins, have been very effective in reducing your risk, and it can actually be used to treat endometrial cancer. And also weight loss, trying to maintain a healthy weight is really important, can help be protective against avoiding endometrial cancer. Oddly enough, smoking has also been associated with decreasing your risk of endometrial cancer, but don't do it. It's still not good for your overall health. Now, if you do get diagnosed with an endometrial cancer, there are things we can do to try to preserve your fertility while maintaining adequate treatment for the cancer itself. The first most important thing is you want to meet with a GYN oncologist as well as a reproductive endocrinologist, so you can assess what are your realistic odds of getting pregnant. The most important thing we can do to try to preserve your fertility is treat it with a progesterone IUD. That's been shown to be effective in up to 80% of cases with endometrial cancer, and still allows for patients to keep their uterus and have a chance of having successful pregnancy in the future. However, not all patients are candidates for this treatment. Having said that, if you're not a candidate for an IUD and you need a hysterectomy, we can still keep your ovaries in place, and then you can follow up with a reproductive endocrinologist like Dr. Kanter, get your get eggs banked, make embryos and use a gestational carrier or surrogate in the future, which will still allow you to have a biological child of your own. Next, I want to move to ovarian cancer. Ovarian cancer is not as common as endometrial cancer. There's about 22,000 cases of it diagnosed this year, but it is highly lethal. Over half the patients that get diagnosed with this cancer will die within 5 years. It's affects 1 in 70 women, but it has one of the highest risks of deaths associated with any cancer. We typically see it present at late stage, and it typically affects women at older age, albeit there are some that affect women of younger age and can affect their fertility. When it comes to ovarian cancer, the biggest risk factor associated with it is your family history. People who have a first degree relative, their risk increases from about 1.5% to about 5% just by having one family relative in the first degree. The other risk is BRCA gene mutations. These are gene mutations that put people at risk for breast cancer, but also ovarian cancer. There are very specific populations that are high risk for developing BRCA mutations, and those include Ashkenazi Jews, African Americans, Hispanics, people of French Canadian descent, Norwegian, Japanese, or Icelandic descent. And so, if you are of this ethnic group and you have a family history of breast cancer or ovarian cancer, reach out to your primary care provider or a gynecologist and ask them for genetic testing so you can get evaluated, because there are steps we can take to mitigate against these risks to try to preserve your fertility. Other risk factors are smoking, so again, don't do it, or periods of long ovulation, of uninterrupted ovulation. Endometriosis has also been associated with an increased risk of ovarian cancer. Also important to note, there are no screening tests for ovarian cancer. So knowing these risk factors, identifying them, and taking action early is super important so that we can do our best to preserve your fertility. Protective factors include birth control pills, multiple pregnancy, and breastfeeding. So these are all steps that you can take to try to reduce your risk. Other things you can do are be removing your fallopian tubes. That reduces your risk of ovarian cancer by about 50%, albeit that will make it so that you can't get pregnant naturally, but with the assistance of ART and reproductive endocrinologists, you can still conceive and have a biological child of your own and carry a pregnancy without your own fallopian tubes. Another potential option is removal of the fallopian tubes and ovaries, albeit this will render you infertile for natural fertility. But again, if you banked eggs and embryos ahead of time, you can still meet with the reproductive endocrinologist and conceive with a uterus in place. Other potential fertility sparing treatments for ovarian cancer include ovarian cystectomies, where we just remove the cystic mass but leave the ovary in place, or removal of just one ovary. This is only recommended in certain select ovarian cancers, though, so we can't do this for everyone. Another potential option is to remove maybe one ovary or both ovaries, but as we said earlier, leaving the uterus in place and doing a delayed hysterectomy after completion of childbearing years. And again, with the assistance of ART and reproductive endocrinologists, we can actually allow you to conceive and give birth to a child without having any ovaries or fallopian tubes, assuming that we've already been proactive and had you bank eggs and embryos. Another thing I think is really important is seek out a second opinion. If somebody's telling you that they have to remove your ovaries and your uterus, seek out a second opinion. It's never a bad idea to hear somebody else's suggestions, and they might be able to offer you a fertility sparing approach for the treatment of ovarian cancer. And then also, if you are someone who's going to need chemotherapy, you can use a medicine called Lupron to try to protect the ovaries if needed while you're getting chemo. Lastly, I'd like to talk about cervical cancer. Cervical cancer is the most common gynecological malignancy worldwide and the second leading cause of death in women worldwide from cancer. It's most common in the Middle East and in Africa, with over 500,000 cases diagnosed every year. Um, Having said that, cervical cancer is one of the cancers where we've really come the farthest in developing fertility sparing approaches for it. Risk factors for cervical cancer. The main risk factor is age and HPV infections. HPV infections are associated with 99% of all cervical cancers. And you can see from our chart here, cervical cancer has a bimodal distribution, meaning it has two age ranges when it seems to affect people. We see that the age incidence really increases in people's mid 20s and peaks in the early 30s, but then they have another peak in their later years, usually around their 80s. But for the focus of this talk, because we're talking about fertility preservation, we'll focus on what young adults can do should they get it. Other risk factors associated with cervical cancer include low socioeconomic status, those with low education levels, immunosuppression, and again, we're seeing it smoking. So, again, do not smoke. The protective factors for cervical cancer, the biggest thing is the HPV vaccination. This is the only vaccine we have in modern medicine that can actually prevent cancers. And so if you haven't gotten your HPV vaccine, get it. The FDA has now increased the age up to age 45. And that's really important. It is 99% effective in reducing your risk of getting an HPV infection. Also, regular screening with pap smears. This is the only cancer we've talked about today that actually has a screening test, and it allows us to pick this cancer up before it even turns into an invasive cancer, where we can take different steps to eradicate the precancer and also preserve your fertility. Again, smoking super important, but also if you're somebody who's adamantly against vaccines, barrier contraception is extremely important as the HPV virus is transmitted sexually. Now, if you are unfortunate enough to be diagnosed with cervical cancer, there are several different treatment options that we have developed over the last decade, which can help preserve your fertility and give you adequate treatment for your cancer. The first is called a LEAP or a conization, and that's when we physically cut out the cancer. This can only be done when we catch the cancer very early or a stage one, but allows us to just remove a small portion of the cervix, and it allows you to maintain the rest of your uterus and cervix and hopefully still preserve your fertility. If your cancer is found slightly more advanced, the next thing we could do is what's called a trachelectomy, where we actually remove the entirety of the cervix and we place a stitch called a cerclage, or it's this band as you see here, to reproduce the ability of the cervix to keep a pregnancy in the uterus. Now, if the cancer is spread beyond the point where we can do a procedure like that and you need to actually get radiation, radiation is very toxic to the uterus and the ovary. And over the last several years, there's been a new technique called a uterine transposition, where we actually detach the uterus from the vagina and reattach it to the belly button. And you actually have periods through your belly button. This allows us to mobilize the uterus out of the radiated field so the radiation doesn't sterilize the uterus or the ovaries. And similarly, if this is a situation where we really have to remove the uterus, we can at least do what we call an ovarian transposition and remove the ovaries out of the radiated field so that they don't get affected. And then again, you can follow up with a reproductive endocrinologist, have those eggs removed from your body. You can make embryos and then use a gestational carrier to get pregnant in the future. Now, there are other cancers, and treatments for these other cancers still can influence your fertility. And so I want to briefly review strategies to preserve your fertility in non gynecologic cancers. Again, the first and foremost steps that you can take to preserve your fertility are getting all of your screening tests done. Those include the mammograms. Most recent recommendations recommend getting a mammogram every 1 to 2 years, starting at age 40, albeit if you want to delay until age 50, that is reasonable. Also, like we said, getting your pap smears, starting those at age 21. And the most recent guidelines for colonoscopies also recommend starting at age 45 now, albeit you can start at age 50 if you have no family history. Um, Also, like we talked about, knowing that family history, super duper important so that you can get genetic testing and take steps ahead of time to reduce your risk of getting these cancers and preserving your fertility. Getting the HPV vaccine, also super important, because not only is HPV associated with cervical cancer, but we're now seeing it increasing rates of head and neck cancers associated with the HPV vaccine, as well as anal cancers. And this vaccine can protect you for all those types of cancers. This vaccine can protect you against all those types of cancers. And then lastly, as we talked about earlier, getting Lupron for ovarian protection should you need chemotherapy for some other sort of cancer like colon cancer, breast cancer, lung cancer. That Lupron can help protect your ovaries so that the chemo itself does not degrade the quality of your ovaries. Take home points I want everybody to take home would be, if you're diagnosed with a cancer and you're concerned how it might affect your fertility, meet with a fertility specialist like Dr. Kanter, or a GYN oncologist like myself, so that we can discuss your concerns and take the appropriate steps to preserve your fertility. Other things is try to reduce your risk or your risk factors, and implement any protective factors that you can to preserve your fertility. Also, know your family history so that you can take the appropriate steps to get genetic testing and then the next steps to mitigate those risks. And also, importantly, do not smoke, because that also affects your cancer risk as well as your fertility risk. I'd like to thank you for listening to our presentation, and I will pass it off to Dr. Kanter to talk to you a little bit more about fertility and what steps you can take in preserving your fertility in the setting of a cancer.
Thank you so much for that, Dr. Pyrzak. I am happy to talk to you all today about fertility preservation from the perspective of a reproductive endocrinologist. So I'm Jessica Kanter. I'm a practicing reproductive endocrinologist in Atlanta at Shady Grove Fertility, or SGF Atlanta. We're based close by, right near Northside Hospital. And today I want to kind of focus on several topics in the realm of fertility. First, I want to just give a brief overview of cancer and fertility, and you've heard a lot about this already from Dr. Pyrzak. And then I want to specifically spend a good bit of time talking about the fertility preservation options for both men and women. And then I think it's also important to kind of glance upon the opportunities for pregnancy after cancer therapies, as you know, this is, I'm sure, a big burning question for those of you who are undergoing new cancer diagnoses or treatments. So let's just start with some facts. You know, annually, we know that there's a very high prevalence of cancer, and nearly 200,000 cancer patients each year are actually diagnosed within their reproductive years. Some cancers have a higher preponderance for diagnosis in early years, including reproductive years. For example, about a quarter of breast cancer patients are actually diagnosed under the age of 45, and almost 200,000 children were diagnosed with cancer in 2021. Now, fortunately for us, with the advances in technologies and the amazing guidance of physicians such as Dr. Pyrzak and other oncology specialists, the 5-year survival rate is really high. And that survival rate is 84% in developed countries. And so there's an estimated 28 million survivors of reproductive age worldwide. And a big question is, what does that mean for future fertility? And the treatments that we undergo for cancer therapies can lead to significant decline in fertility, depending on what those therapies are, which I'll talk about in a moment. Specifically for men, this can lead to conditions such as oligospermia, where there's a lower sperm count, or even azoospermia, where there are no sperm in the ejaculate. And these conditions can make it more difficult, if not impossible, to conceive in the setting of azospermia. For women, this can lead to infertility from a number of different kind of etiologies. There can be surgical sterility, like some of the things Dr. Pyrzak was talking about, where if the fallopian tubes have been removed, there's no pathway within the body for eggs and sperm to meet. Or if the uterus has been removed, there's no womb in which a woman can carry a pregnancy. Or if the ovaries have been removed, she no longer has the ability to create her own eggs to create a pregnancy. These treatments can cause premature ovarian failure. So even though the ovaries may still be in place, they may have been adversely affected enough by the treatments that they no longer function and no longer can create a healthy egg. And there may also be increased risks of miscarriage related to prior treatments based on kind of damage to our gametes, to our eggs, to our sperm. So the threats to fertility through cancer treatments include chemotherapy, which is kind of drug-based treatment of cancers, radiation therapy, and surgical therapy. And the risk of infertility really spans all cancer types, both genders and all ethnicities. So it's really something that needs to be considered for anyone undergoing cancer therapy in their reproductive years. And really important factors to consider with regards to what's the best option for preserving my fertility, as well as what is the impact on my fertility, are the age at which you receive your diagnosis and are undergoing your treatments, the drug or treatment type that you're undergoing, the dosages of those treatments. There's a very significant dose dependent impact on our fertility, and then the location of those therapies. So if you're having radiation therapy, for example, are you having radiation therapy in the upper part of the body, or is it for a woman in the lower part of the body around the area where the ovaries lie? And this is where things like ovarian transposition and other items that Dr. Pyrzak brought up come into play, which we'll talk about again in a moment. So it's important to note that there are options for fertility preservation, both not only before and during treatment, but also after treatment. And they're available for both men and women. Importantly, and we won't spend a lot of time talking about this today, there are also experimental techniques that show promise for individuals who are pre-puberty. And then finally, for individuals who have lost fertility through the course of fertility treatments and did not have the opportunity to preserve fertility in one of the methods that we will talk about, there are even options for patients with third-party parenting, things such as using a gestational carrier, using donated eggs, donated sperm. And again, we can talk about these a little bit more to follow. So I always tell my patients, there's not one right way to build a family. Families look very different. And the right way is the right way, the way that is right for your family. So let's talk a little bit about the fertility preservation options for men first. There's an option for sperm banking and testicular tissue freezing and testicular sperm extraction before treatment. And then there's also the opportunity for things like testicular sperm extraction, sperm donation, and adoption after treatment. So let's talk about these in a little bit more detail. From a sperm banking perspective, this is a relatively easy way to preserve fertility. And in this method, a semen sample is collected, analyzed, frozen, and stored for future use. This can only be done after puberty. It is an outpatient procedure, and there are very high success rates using these sperm in the future. And depending on kind of the amount of sperm that is preserved, will be dependent on what method of conception in the future is a viable option. For some couples, they're able to preserve multiple vials of sperm and even consider less invasive options of pregnancy, such as doing insemination, where a sample of sperm is placed inside a woman's uterus at the time of ovulation. And this can be a less invasive method of successful conception in the future. There are also really high success rates through techniques like IVF and ICSI, which is where we take a single sperm and inject it into a single egg. So even if there are very low sperm counts, if sometimes we see that in the context of having a cancer diagnosis, because of the stress that this causes on the body, the sperm counts are reduced. And so they may not be high levels of sperm available to freeze for the future, but even low numbers can be used with these techniques. So this is incredibly helpful. Now, it's also important to know that the time is preferably before treatment is initiated, because many of these cancer therapies, particularly thinking about chemotherapies, can also impact the DNA of the sperm. And that DNA damage can lead to adverse outcomes for future pregnancy as well. So banking sperm ahead of any treatments is of the utmost importance. Now, I also talked about testicular sperm extraction. So if there are no sperm present in the semen sample, then there is the option to actually take a testicular tissue. And so in this process, it is a pretty invasive surgical procedure where testicular tissue is actually removed and fragmented and examined for sperm. So the sperm can be extracted directly from the testes, and the sperm can be used immediately if that's kind of the plan that's in place, or stored for future use. It is an outpatient surgical procedure typically performed by a reproductive urologist. So one who has not only urologic training, but also specialization within the fertility world in urology. And the success rates are quite high when this method is combined with IVF, up to 70% success. It is considered an experimental procedure for boys who are prepubertal, as this have not quite developed to this state that we would typically see them for men who are post puberty. But there are, again, still potentially options here. Now, for women, there's a little bit more variety here. And a lot of this is kind of dependent on what the treatments are that the woman is undergoing. Again, like I said, there's a lot of variability based on the type of treatment, whether it's chemotherapy, radiation therapy, what the dose is, what the location is. But kind of to go through this a little bit of a laundry list, and I'll try to focus in on kind of the biggest options. There are options for both egg or embryo cryopreservation. So freezing eggs alone without fertilization with the sperm for someone who doesn't have a committed partner at that time, or may have moral or ethical qualms with creating embryos. This is a great option. Embryo cryopreservation, the only difference is that once we retrieve the eggs through the IVF procedure, those are fertilized with sperm. They can be then preserved for the future in the embryo state, and potentially even genetically tested to have more genetic information on those embryos for the future. Both of these techniques can be utilized before or after therapy. Now, the major caveat is that with after therapy, if the cancer therapy is expected to reduce ovarian reserve, that can reduce the success rates of these therapies. So typically considering doing these approaches ahead of therapies is recommended. Now, there's also kind of a more experimental option for ovarian tissue cryopreservation. This is, and I'll talk about this in a little bit more detail to follow, and when it is appropriate. Dr. Pyrzak had glanced on using Lupron therapy, which is a GnRH analog treatment. And I'll talk about this again a little bit more, but basically causing a medical menopause in order to protect the ovaries for the future. I know Dr. Pyrzak spent quite a bit of time talking about fertility sparing surgery, and I think this fertility sparing surgery is a really important thing to consider. And, I would also encourage you with undergoing kind of your investigation into options for our treatment, that seeking a second opinion is really incredibly important. And I can't agree more with what Dr. Pyrzak said. And then ovarian transposition, again, another option with regards to moving ovaries, for example, out of the zone of radiation if you're having radiation therapy for, say, a cervical cancer or otherwise. And then there's also the options after undergoing treatment for potentially natural conception. Some women will have return of their fertility depending on what their treatment of choice is, and may be able to conceive on their own and never need assisted reproductive technologies. There are the options for IVF, utilizing donor egg or donor embryos, as I talked about before, adoption, and the utilization of a gestational carrier to carry a pregnancy if the uterus is damaged during the course of treatment. Just to kind of go through what embryo and egg cryopreservation looks like on a kind of a bird's eye view. And basically the stimulation time only takes about 2 weeks on average to be able to take the appropriate injection medications and stimulate the ovaries to retrieve the eggs. And so basically how this happens is after you receive a cancer diagnosis and meet with an oncologist, they will refer you to a reproductive endocrinologist like myself. Typically most practices have practices in place that we allow oncologic patients to get in within a couple of days of that referral. We don't want you waiting 3 months for that discussion. We know this is all very time sensitive. Once you've met with a reproductive endocrinologist, you typically start injections within the next week or so. The quicker, the better. And these injection medicines basically stimulate your ovaries to grow as many follicles as possible, these little black circles you can see here. And each one of these follicles houses an egg. And the goal is to have as many eggs develop as possible in a given cycle instead of just one, as is typical for a natural cycle. Once these eggs have developed, a surgical procedure called an egg retrieval is undertaken, where under sedation, a needle is guided into the ovaries to drain these follicles and obtain the eggs. The eggs can then be frozen for future use or fertilized with sperm and then subsequently frozen about 5 to 7 days later as embryos. And again, if embryos are the route of choice, those can be genetically tested prior to that freeze. Once that is complete, then the patient is able to go on with their cancer therapy initiation and without too significant of a delay typically, which is great, being diligent about getting to that treatment in a timely fashion. Now, for embryo freezing, as I mentioned, the mature eggs are fertilized, frozen, and stored. The process, we say, takes about 2 to 6 weeks. In the most efficient setting, it's about 2 weeks. And we say, depending on the menstrual cycle, if there is time, the typical timing to start an IVF stimulation is with the beginning of the menstrual cycle. But actually, the process can be started at any time within the cycle. And we've learned a lot about that of late. And the clinical pregnancy rates are quite high, about 45% per embryo transfer. With embryos that have been genetically tested, this rate becomes higher because we're ruling out genetic changes that would not allow that embryo to be successful. And thousands of babies have been born worldwide through this process. Now, the difference with egg freezing is that the mature eggs are removed, frozen, and stored. It must be done in women who have already undergone puberty. And again, the process is a similar timeline. The eggs can be thawed in the future to create embryos. Importantly, not all of the eggs will typically survive the thaw process. So if creating embryos is then that does bear some advantage with regards to survivorship of the gametes when they come out of the freezer. And then I mentioned that ovarian tissue freezing is experimental. This is a process where the ovaries are removed laparoscopically and then strips of the ovaries are frozen and stored for the future. And these strips of ovary can then be transplanted back into the body to restore hormone function and to grow eggs. Again, experimental, only one live birth to my knowledge to date, but this is something becoming more prime time as we have more data to support it in the future, depending on clinical circumstance. And then Dr. Pyrzak had spoken about the GnRH analog treatment, which is a medication called Lupron or Luprolide. This is an injection medicine that can be administered during chemotherapy to help suppress the ovaries, put them into a medical menopause. And this can help suppress the damage to the immature follicles and reduce the chance of infertility in the future. It's best used in women who have completed puberty already, and it started anywhere as soon as 1 week to 6 months prior to chemotherapy. Now, it's important to know that the research varies with regards to success rates of this treatment. The strongest research in Lupron or GnRH analog therapy is in women who have undergone breast cancer treatment. And in those women, there is a suggestion that there are improved pregnancy rates after treatment. But in other in other cancers, this has been less well studied. But overall, we believe that it's overall not a harmful adjunct to consider to help protect the ovaries if you're receiving chemotherapy, even for another cancer. I think one of the examples Dr. Pyrzak used was colon cancer. Now, I mentioned that there's not one way to build a family, and so sometimes there is no time to undergo any sort of fertility sparing surgery or any egg or embryo cryopreservation ahead of a treatment. And so if that is to happen, then donor eggs and donor embryos are a beautiful way to grow one's family. And basically, this process involves the use of donated eggs from a young woman who provides details such as physical attributes, educational background, genetic screening, etc. And these donors can be anonymous or there can be known donors. Some people will call upon family members or otherwise to donate gametes to help them build their families. And infertile or menopausal patients are able to actually carry a pregnancy using these donor eggs and their partner's sperm so that they can then be genetically related to the couple through the partner. And then there are very high success rates with this. And I should mention here that not only is there the option for donor gametes through the female side through eggs, but also through sperm. And so if there is a permanent loss of testicular function and sperm production for a man, donor sperm is another wonderful way to build a family. And then we also finally, kind of from a fertility perspective, there is the option of utilizing a gestational carrier if the function of the uterus is damaged or the uterus is removed in its entirety during the course of cancer therapy. And in this process, one or more, it's really just one embryo is transferred to the uterus of a gestational carrier. And if the ovaries or eggs are damaged as well, then a donor egg could be used. But if the ovaries are still functioning or fertility has been preserved through egg or embryo freezing in the past, then these can be a couple's own eggs utilized for this process. The pregnancy rates vary. A lot of this is based on kind of the quality of the embryo, the age at which the egg was sourced to create the embryo in question. But it is important to note that surrogacy laws are very variable from state to state, and not all states in the United States do allow for gestational surrogacy or gestational carriers. So something definitely to investigate. From a financial perspective, I would note that, the fertility treatments are typically very expensive. It's a very high technology, and they're a very complex process. And given these costs, many clinics do offer treatment at reduced costs, mine included, to those undergoing cancer therapies. And it's important to know that there are numerous grant and pharmacy programs also to help provide medications at low to no cost to eligible patients. I was just talking to one of the pharmacies about this yesterday, actually. And so I would encourage you to not worry about kind of the financial aspects from a fertility, but just have the conversation. And once you've had that conversation, your reproductive endocrinologist can arm you with information on kind of financial options, as well as the opportunities for assistance through grants and pharmacy programs like we talked about. Now, importantly, I did want to spend just a little bit of time here at the end talking about pregnancy after cancer therapies. And I want to note that it's important to note that pregnancy after cancer treatment does not necessarily trigger recurrence, even after breast cancer. And it's important to know that the developing gametes, so the developing eggs and sperm, may be damaged by chemotherapy and radiation, but there may be mechanisms within the body to repair this damage. And so sometimes waiting a certain amount of time after these therapies, 6 to 12 months or more, and I'll talk about these specific timelines for men in just a minute, can help to allow the eggs or sperm to recover from that. The data show us that the rate of birth defects of children born to cancer survivors is actually similar to that of the general public, about a 2 to 3% risk. And there's no unusual cancer risk that's been identified in the offspring of cancer survivors, except in families who have a genetic preponderance for cancer, things like the BRCA syndrome and others. And then from the male perspective, there aren't very clear data on, how sperm are affected long term. But from the information that we do have, it shows us that the sperm DNA damage to sperm can be present up to 24 months post chemotherapy. Believe it or not, it's quite a long time. And so, based on this, the two different governing bodies. First, the European Society for Medical Oncology recommends delaying childbearing for at least 12 months after cancer therapy. And the American Urological Association and American Society for Reproductive Medicine also recommend avoiding pregnancy for at least 12 months post completion of chemotherapy or radiation. The AUA and ASRM also recommend that a semen analysis be performed at least 12 months and preferably 24 months after treatment completion, because there still can be some rebound in sperm production. And again, as I mentioned previously, testicular sperm extraction is an option for men who are persistently azoospermic, meaning no sperm after therapies. And so these are the big kind of considerations for pregnancy down the line. And again, I can't stress enough, kind of talking to a reproductive endocrinologist can really arm you with information on what your options are. And then really talking very carefully with your oncologist about what those options are up front from a treatment perspective to help preserve fertility off the bat and reduce risk to future fertility. Something that's of interest to you. But thank you so much for listening to this. And I'm happy now to kind of take questions that have been curated related to this.
That was great. Thank you guys so much. I always learn something. I feel like I know a lot about this topic and have supported women as a navigator, helping newly diagnosed patients through this process now for a long time, but I always learn something from these presentations. So thank you. I wanted to see if we could just maybe have a little conversation about sort of what the interplay looks like. So when a newly diagnosed patient is told that they need to undergo chemotherapy or surgery or some sort of treatment that may impact their fertility, and then sort of like, let's say it's a patient with breast cancer, for example. So she gets diagnosed. Obviously, depending on the situation, she might be recommended for chemotherapy, and there would be some urgency to getting her started with that. So can you talk a little bit, Dr. Kanter, about how you sort of manage that? I know you talked about the 2-week process in terms of how long it might take to do fertility preservation itself, but what does that look like? So the patient comes in to see you, and then what testing is involved, and sort of what might the patient be considering as she's making the decision about whether to proceed with fertility preservation?
Great question. So basically, once a patient has that first visit with a reproductive endocrinologist, they're armed with information about what the options are for fertility preservation, like what we just talked about. At that time, some testing is recommended, including basic lab testing and ultrasound testing to understand her ovarian reserve. And typically, this involves just doing a vaginal ultrasound to kind of count the number of follicles available on her ovaries, as well as some hormonal testing. There are two main hormones that we use. One can only be done at a certain time in the menstrual cycle, called the FSH hormone. So typically, this can't actually be done at that first visit unless we have very fortuitous timing as to when she's coming in to see us. Otherwise, it's not accurate. But there's another hormone that's really useful called AMH, or anti-Mullerian hormone. And this is a hormone that's produced by the cells that surround the eggs within the ovary, so that the more of those eggs we have, the more of that hormone we have. And this is a really helpful adjunct in dosing medications and understanding how a woman might respond to that process. So those labs are done. The labs and ultrasound are done, as well as some other ancillary labs like checking her baseline blood counts for safety of an egg retrieval, checking infectious disease blood work. Once that is done, then we start the process of preparing her for the IVF process, if that's something she's interested in. And that preparation usually takes about a week to kind of get all of our ducks in a row so that we can be talking with the pharmacies to get medication, setting up a protocol, setting up all of our consents and otherwise. But we have had patients start as soon as within a few days. It just really depends on the clinical scenario because, as you mentioned, Emily, sometimes time is of the essence, and we don't have 3 weeks to wait in total before moving into chemotherapy. We really need to stay as close to that 2-week timeline as possible. So it is very variable. Now, I think the most important other thing is that as reproductive endocrinologists, we're typically communicating freely with that oncologist who is managing that patient's care and ensuring that, number one, is it safe for this patient to undergo this procedure? Number two, is it safe for them to delay their treatment by 2 weeks, 3 weeks, whatever we're anticipating that timeline to be? And number three, are there any other things that we need to consider in going through that chemotherapy and through that, fertility preservation? For example, some individuals may need other adjuncts like a blood thinner during that process. And so we're very cautious and very communicative with our oncologist in going through these processes. And sometimes I see a patient who we have this conversation and they really can't wait. And so we give them Lupron suppression and they move straight into their treatment within a few days. So it's really just dependent on that kind of open line of communication between reproductive endocrinology and oncology.
Yeah, I think teamwork and the care coordination, is important. And I think just opening up those lines of communication is really important. So thank you. That's really helpful. And Dr. Pyrzak, just kind of dovetailing on that, when you have a patient that is newly diagnosed with a GYN malignancy, what is that conversation like? Does she do you automatically ask a woman who's still of childbearing age whether she is interested in fertility preservation? How does this conversation come up? Is it part of the consultation? Is it up to the patient to kind of state her intentions as far as her family plans, or is that something that you're routinely asking to a newly diagnosed patient?
That's actually the first question that I ask a patient when they come to see me is what are your fertility desires? Because that really shapes the whole context of how our conversation is going to go. This obviously varies from provider to provider and how they approach the patient. But for me, that's the first thing that we talk about. And I would advocate patients to really advocate for yourself that if a doctor doesn't ask you about that, bring it up on your own. Don't be shy. Don't be afraid to bring up these points because these are crucial in determining what would be the next best steps of treatment. Whenever I see a patient who's of reproductive age, the first thing I said is we want to talk about are what are your desires? And I work very closely with reproductive endocrinologists like Dr. Kanter. There's probably not a week that doesn't go by that I'm not reaching out to her about a patient and trying to get those patients plugged in with her so that they can, right as we're still doing our workup and evaluation, Dr. Kanter is simultaneously doing her similar workup and evaluation so that we can get all those needs and expectations met. And I think the other thing is while everybody is very anxious about their cancer and they want to expedite their treatment as fast as possible, the reality is a delay of a week or two usually doesn't make a big difference in the overall oncologic outcome for the overwhelming majority of circumstances. And so we can do a stepwise approach and where we just remove the mass with the one ovary or part of the mass and not the whole ovary, gather some more data points so we can say, okay, how aggressive is this? Because the reality is not all cancers are created the same, even within a cancer site itself. For example, like ovarian cancer, not all ovarian cancers are the same. I use the analogy if I kind of think of like ovarian cancer is kind of like a dog, like it's a very broad generic term. But within dogs, you've got different breeds, right? You've got Labradors, they're not that bad. They might give you a little growl or a nip, but they're really not that bad. But then you've got your bulldogs and your Rottweilers that are more aggressive. And the reality is, we won't know the breed of a cancer until we either have a tissue biopsy or we've excised it. And so it's very reasonable to do a stepwise approach in working these patients up, where we say, hey, rather than trying to do one stop shopping and doing all the surgeries all at once, let's just get that one mass out, pause, take a break, and regroup. And that way we can have a joint conversation with myself, the patient, our reproductive endocrinologist like Dr. Kanter, so that we can really make sure that we are optimizing our reproductive outcomes and meeting the goals of our patient.
That's great. I think just that shared decision making is so important to patients to know that they're sort of the center of that conversation. And I really appreciate that approach. With that said, how do y'all sort of coordinate together? So, like, what would the sequence look like for a patient who's diagnosed with cancer who maybe you're sending for reproductive endocrinology consults? Because I would guess that a lot of patients might go for that consult and then, make a decision, determine sort of based on perhaps the barriers. Maybe it's the cost, or maybe it's the amount of time that it's going to take, and kind of weigh that decision in terms of how to proceed with kind of where their values are. Like, is this something I've seen breast cancer patients before, for example, who, that's the number one priority. They absolutely want to go through fertility preservation. So they don't mind waiting that 2 or 3 weeks that it may take to get through that cycle. Another patient may say, what, I'm okay. I've got, 2 healthy children at home, and I wanted a third. I thought maybe I was going to have additional children, but I'm okay moving forward. So, like, tell me a little bit about how that works with as providers, kind of how y'all coordinate the patient's consult, and then how that sort of how do you kind of take care of the patient together? I guess y'all can take turns answering.
Yeah, I mean, I think, Emily, as we were talking about before, I think that open line of communication between the oncologist and the reproductive endocrinologist is so important. Typically, Dr. Pyrzak and I have a longstanding history together, so we're very quick to call one another, update on the plan, update on kind of what our goals are for the patient from each of our sides to make sure it's in keeping with what's best for that patient based on her goals. But I would say I have this open line of communication with other oncologists throughout the different specialties. But Dr. Pierce, I don't know if you have other kind of thoughts there.
I would reiterate those same statements. I think we're very fortunate in living in the Metro Atlanta area that we have really an amazing community of reproductive endocrinologists who I think go above and beyond to make sure that they are always reaching out to us oncology providers to expedite our patients' care, giving them the best information they need so that they can make an informed decision on how they want to approach their care. And so it's luckily with modern technology too, it's not a very big burden. We can text, we can email. There's so many ways that we can all reach out to each other now that it's much more streamlined than say when we were younger. Not that we're not young, we're still very young.
And that's great. And I'll kind of just continuing on that same line of thought. I know Dr. Kanter talked about in her slides sort of when it might be an appropriate time to sort of revisit after treatment, sort of when it might be safe to attempt pregnancy or to sort of restart that conversation. Maybe somebody was not partnered previously, and when they were going through treatment, now they're in a relationship and they're ready to start their family. They're doing well. They're one of those lucky cancer survivors who's out some time out. What are y'all's thoughts in terms of how sort of to proceed, or what to recommend as far as when it's appropriate to consider pregnancy or to consider that fertility conversation in terms of what we're going to do now that we've sort of completed cancer treatment?
Yeah, I think that's a great question in that unfortunately there's a lot of variability there depending on the patient's cancer diagnosis, what their treatment was, and how their monitoring has been going post treatment. Are they fully in remission? Are they monitoring? What are they on? Other kind of hormonal therapies like letrozole, tamoxifen, etc. post treatment, and all of these things need to be weighed. I think the best place to start from my perspective is by educating yourself on what those options are, by both talking to your oncologist about their opinions and when it's safe for you to conceive, but also talking to a reproductive endocrinologist early on. There are sometimes considerations, for example, in women who are undergoing post treatment hormonal therapy after breast cancers, that they may consider taking a pause in those treatments to create embryos through IVF and then going back on those treatments because they're planning to be on those treatments for, say, 5 years post treatment. But really, again, all about the communication. Talk to your oncologist. Also talk to an endocrinologist. You're not going to regret having that conversation. It's only going to arm you with information. And I would echo, what Dr. Pyrzak said earlier, is that there are a lot of amazing reproductive endocrinologists in the Atlanta area, and not only in my practice, but in many others. And we're all very collegial. We just want you to get the help and information that you need.
Thank y'all. And I just have one more question. I'm cognizant that our time is almost up, but we are focusing more and more on cancer prevention with high risk clinics and, identifying patients earlier that might be at risk for cancer. So one of the things that I think this allows us is to have these conversations about fertility preservation ahead of time. So when we know that somebody is at risk because of their family history, maybe they have a proven, BRCA mutation, or perhaps they are at risk for, another type of cancer based on that risk. What are some of the things, and Dr. Pyrzak did go through this in your presentation, so thank you for detailing, but what are some of the things that you would counsel someone that's known to be high risk for cancer sort of ahead of time so that they can do the best that they can to preserve their fertility and their opportunity for parenthood down the road?
Yeah, so I see a lot of patients who come in with, recently or newly diagnosed genetic mutations. And it's something that we have a great program here at Northside where we have high risk clinics, and other institutions like Piedmont and Emory similarly have same clinics like that. And I think the biggest thing is education, making sure people understand what their risks are and what processes we can take to mitigate against those risks. For every, genetic disorder, it's a little bit different. In my world, that the big ones we worry about are that BRCA mutation. And one thing that we have that is very exciting is we have a clinical trial now, where we are allowing women who are still of reproductive age, but still at high risk for developing ovarian cancer, where we actually remove their fallopian tubes, but leave the uterus and the ovaries. This is still an experimental procedure in understanding if it really reduces the risk. But the thought is now that most ovarian cancer isn't ovarian cancer at all, but it's actually fallopian tube cancer. And it's just that by the time we catch it, we can't tell the difference if it's fallopian tube cancer or ovarian cancer. And by removing just the fallopian tubes, we think we can drastically reduce people's risk. And while that removing the tubes will make you infertile from a tubal factor infertility, with the assistance of advanced reproductive technologies and our reproductive endocrinologist partners, you can still get pregnant, make embryos, use IVF, and carry a pregnancy to term, even though you have no fallopian tubes. And so that's kind of one of the biggest, most exciting things in helping people mitigate those risks with BRCA mutations.
I think it's also important, just to piggyback off of that, with knowing genetic heritable risks, another thing that's really amazing about the technologies we have available to us is that we have the ability through IVF to potentially consider genetic testing for these heritable traits so as not to pass on these risks to your children. And that's, a really incredible technology that's helping people to build their families in the way that they want. So another thing to
Thank
consider.
you. I was going to be my follow-up question, so you beat me to it. So that's great. And thank you for bringing up the resource question, I think, or the topic of, how do we afford this? And so I just want to say, as a cancer, nurse and somebody that has often having these conversations, I just want to kind of echo what you had said, Dr. Kanter, about resources, that, it's better to have the conversation and explore the resources and opportunities up front. I work with Team Maggie, so, we are a local charity that can help to fund fertility preservation. It certainly doesn't cover the entire cost, but it can help defray some of those costs. And so I appreciate you bringing that up. Just in your experience, how likely is it that insurance or any sort of medical coverage might be available? I know some employment benefits packages now cover fertility preservation. So can you talk a little bit about what those resources might look like and how somebody might pay for this if they, can't afford upfront costs?
Yeah. That's a great question. I feel like we're seeing more and more insurance benefits towards fertility because it's being recognized as a medical necessity and a medical problem in having infertility. And so it is incredibly variable from company to company, from insurance to insurance, and from even what specific plan you have within a single insurance. But something that I encourage people to look at when looking at both their insurance and their partner's insurance and deciding kind of what insurance plans to be on. Now, if there are still many, many insurances that don't cover this at all, and may not even cover some of the testing. And so, as I mentioned, a lot of clinics, my clinic included, will provide these services at a reduced, like at cost, if you will, process out of an effort to try to get people the care they need. But there are options for things like financing, obtaining loans, paying off over time, and then lots of grants. There are a lot of grant opportunities through fabulous programs like Maggie's Dream, the Jewish Fertility Foundation, Fertility for Colored Girls. There are so many organizations within the Atlanta area that offer a lot of support here.
Well, thank you so much. I think that is probably all that we have time for.
Thank you both, Dr. Kanter and Dr. Pyrzak and Emily, for that great Q&A. We are going to wrap things up with some final thoughts before we close out. But again, I do want to thank all of you for sharing your time and expertise for today's program. And before we close out, I encourage everyone to visit Cancer Support Community Atlanta's website, cscatlanta.org, where you can see a complete list of the oncology support programs offered for free. And of course, you can also visit other video resources like this one. So before we close out, I'm going to throw it out to you, Dr. Kanter, Dr. Pyrzak, and Emily for some final thoughts. And Dr. Kanter, we can go ahead and start with you.
Great. I would say, in closing, I think the bottom line here is communication is key. Communicate, get your resources together your resources from your oncologist, from a reproductive endocrinologist, and just have the conversations. Ask the hard questions. Arm yourself with information.
I would completely agree. Be an advocate for yourself. If you don't feel like you're getting the information that you need, don't be afraid to speak up or to ask for a second opinion if you are concerned about the information you're getting. The great thing about being in Atlanta is we are probably the only city in the state of Georgia where we have a breadth of reproductive endocrinologists, GYN oncologists, and oncologists of varying specialties. And so advocate for yourself if you're concerned.
Thank you guys so much for this conversation. I think it's really rich and will be beneficial to so many people who are struggling with their fertility and their options, either during a cancer diagnosis or after. I really appreciate both of you for taking the time and for your expertise. And thank you for participating. Thanks everybody for listening.
Thank you for having us. It was a pleasure.
Was a pleasure.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org. Or follow us on Facebook. We'll be sharing additional information on upcoming programs.